Good evening, one and all. At the outset, I would like to thank Dr. Mohan Rajan sir for the nice words and Bhashan Lam for the opportunity, and also AOC. So I was asked to speak on my what all are the lenses regarding this extent depth of focus IOLs. My experience I'm here to share with you. Before this, I just would like to say an incident. When I was a very young 4-year-old.
Little louder.
Little louder. Now I'm audible better?
Yeah, better.
So I was only 4-year or 5-year-old, I guess. We all went to Tirupati. My grandmother, by then, she used to have very thick glasses. I think she had her cataracts done. Those days, there was no IOL implanted. So poor lady, the glasses fell down and broken. And I remember viewing Lord Balaji's darshan with one of the glass pieces she could get, and that was imprinted in my mind, like, whenever any cataract patient comes, I would like to offer them, no glasses at all. So these were the adverts we used to give when presbyopia clinic started. Majority of cataract patients, majority of them, although these Googlers and all ask, but majority of them, they think if you put a lens inside, they don't have to wear glasses. Still under the wrong notion. So we put this is the lens you opted for. So with this, you need to wear glasses for far, intermediate, and near. And then now this lens multifocal, no glasses for anything. Now comes the another option we added: glasses not required for far, and glasses not required for near, but you have to wear, other way. Glasses not required for far and intermediate, but near you have to wear. That's how the EDOF we introduced. So, and I love this caption. When Dr. Arthur Cummings underwent his LASIK way back, he put an article. He wrote a nice article about his experience. So I was very impressed with this caption. I always wanted to use: the best eyewear is no eyewear at all. So when I started my practice of multifocals, I really love multifocals. I offer majority of my patients these multifocals. From bifocal to trifocals, we have seen how these lenses also evolved. And the so-called glare halos problems also, majority of these manufacturers addressed it. In fact, these multifocals I implanted in all my family members. But then why this new lens? So I think there's so much of noise about these glare halos, photic phenomena. And some patients, because of the knowledge on social media or whatever it is, they come and ask. One of the patients asked me, "Doctor, how many multifocals you removed from the eye?" I said, "Why would I do that?" "No, my family doctor told me this is not a good one. It is very troublesome, very bothersome when you drive night times and all. I don't want these lenses. You give me other option. I don't mind wearing glasses." These were the things, the multifocals, they have a wrong notion about it. But anyway, all said and done, now the manufacturers have found out the solution. So that's how I slowly started adding this EDOF in my practice. So now I'm slowly, I think it's on rise in my volume of cataracts. So that ideal EDOF lens, the optic principle, unlike a monofocal, when there is a focus shifted, there is a blur circuit at the retina. But an EDOF can create a single elongated focus, which extends the focus. So a good depth of focus is created so that a good intermediate vision is processed, but without compromising the retinal image quality. So we have various EDOF IOLs now, but is there any ideal EDOF? We have the small aperture IOL where the field is reduced, so it is only supposed to implant in non-dominant eye. And all know about the diffractive IOLs, also refractive. Again, the same kind of trouble of photic phenomena, glare and halos. And then there comes this non-diffractive IOLs. We have various optic principles, and I have used all of it, whatever I'm showing, except the small aperture. So each surgeon has their own preferences. Each one has your, you want to drive a BMW, or you, depending on the engine performance, how you choose your cars or mobiles. Similarly, I think majority surgeons have their own preference in terms of whether it's monofocal, multifocal, or EDOF IOLs. So I personally now zero it upon 3 non-diffractive EDOF IOLs. The VVT from Alcon, this optic principle, it has a central elevation and curvature change. So these two elements acting simultaneously manipulate the wavefront, stretching forward and stretching backward, creating a hyperopic and myopic kind of focus. So where the manipulation, in turn, gives a continuous range of your focus. So that's how this principle, and then there is not much of photic phenomena, but every lens has its own demerits. This is a beautiful one, but then in the near vision, you have to tell your patients that it cannot achieve perfect near vision, although it gives good distance and intermediate. So that's why it's become easy for the surgeon to impress the patient that, I will provide you this, but you have to wear glasses. So acceptance from the patients is easy for the surgeons to handle, unlike in a multifocal situation. So my data with Alcon VVT is, so majority of them for the distance, they got 6x6, like above 80% of them reading 6x9 for far. And for the intermediate, 78% achieved N6, and more than 80% got N8. And for the coming to the near vision, this 54% achieved N6. This is my own data. So more than 70% were reading N8. And this want to share. After having done so many VVTs, then when they claim that it's behavior like a monofocal, so definitely it has a role in certain pathologies involving optic nerve or retina. So the gentleman owns a very popular TV channel in Hyderabad, and he has a very huge room, and he sits and he watches every day the news, like these, even the majority that TV channel, like media tycoons, they also manipulate the politics. Yeah, so he wants to watch the TV from one certain distance, and also want to look at he's a very tall guy. But don't know why when has one other surgeon implanted a multifocal, then he was having very bad kind of retina, totally burnt out, extensively done PRP. So the other eye, when he came to me, I gave VVT, and definitely he was feeling much, much better with its outcome than the multifocal implanted in his other eye. Magnificent from IOCare, it is also a surprise for me. I don't know, I gathered data of this lens from various information sources. So it is having hypersphericity and a negative on the anterior side and positive on the posterior side, which is helping these depth of focus around 1.5 to 2 diopters. That's what they claim. But then definitely a better kind of depth of focus was achieved by this lens. And it's a really pleasant surprise for me, because economically, even if patient cannot afford these expensive multifocal or EDOF IOLs, this has definitely a place. And this is my sister's friend. She had very small pupil, and long time ago she had third nerve palsy. She came to me for the very dense cataract. So I thought, let me put Magnificent and check whether will she, because I thought it is kind of a not a very good outcome I expected in her case. But a real surprise for me with this lens and in her eye, I don't know, look at her pupil size. Probably the pupil size also plays a role in this because small apertures, giving more depth of focus. Combined elements, I don't know, she really was so happy. And the other eye also, it was a normal eye, but then eventually in binocularly, she's extremely happy. And magnificent, this is all I collect from the 30 years of data. So the distance for far with this lens is almost 61%. Do you have a time bound? I can...
Maybe another 2-3 yeah.
5 minutes.
Yeah, 5 minutes, okay.
And for the distance is almost 80% of them achieved 6/9, and intermediate vision almost 80%, and the near vision was around 50%, N6 rather. I was talking about N8 rather. So then comes this LuxSmart from Bosch & Lomb. So this is a non-diffractive IOL. The optic principle in this is it has a central EDOF center located in the central 2 mm area, and it has combination of fourth and sixth order with opposite signs. That's where this lens has the point of, when you have opposite signs of spherical aberrations acting together, the depth of focus definitely has a enhancement rather than one spherical aberration like negative spherical sphericity, but combination with opposite signs is the one which increases the depth of focus. And it has the refractive zone which meant for the distance, and there is a transition zone in between which helps to maintain the contrast sensitivity, that means no light loss. And it has fore fixation which sits very well, and it's a hydrophobic, and it can go into 2.2 mm incision, but till now they have not provided with the toric version, so far I implanted only non-toric. So this is my data of LuxSmart. Today morning I had this free paper presentation on this. So 35 patients, 50 eyes we presented. With the even age group, if you see, I put 24-year-old also. So I'll show you that video. So, and we included 5 myopes. 2 patients are having ERM, but very not clinically significantly affected their visual acuity. And 1 patient had amblyopia. And majority of them underwent femtophaco procedure. And bilaterally, we implanted in 30 eyes. And 20 patients had single eye. So the mean UDVA logMAR achieved was 0.22. This is like ANSI standards. That is how EDOF lens should have. And for the distance, 80% of them were reading 6/9 on Snellen's chart. Only 6% of them lost more than 3 lines, that is 6/12 partial, due to the myopic shift happened. Initial cases, there was a myopic shift on biometry. So then we started, the A constant was 118.4 for the optical, but then, surgeon A constant also important. That's how we understood that it should be little whatever showing, 0.4, 0.5. Below that you should, we started doing that way. Then the results were definitely optimized. And coming to the intermediate vision, 80% achieved N6 and 96% achieved N8. And similarly, the near vision, 76% achieved N6 and 86% achieved N8. And so far, no photic phenomena. None of them, we asked for a questionnaire and none of them complained photic phenomena. And on Ardent chart, we checked the contrast sensitivity. There's a 10% loss of contrast sensitivity with this lens. And majority are very happy. 80% of them achieved spectacle independence. And defocus curve also was assessed bilaterally. This majority of them achieved 6/9 on Sallen's chart. So the IOL master was on 700, we choose, and Barrett's universal 2. Initial cases, I started taking my calculation on Varian because I like Varian. The reason is that other biometrics only they predict this spherical error, but then on Varian it gives also sphere and cylindrical predicted error. So that's what I used to take this. So, but then I realized I should use this only for the incision location. And this lens needs priming. It's very important. You have to inject BSS in the either side of the cartridge and a little bit of visco at the tip of the cartridge, and you have to wait for 30 seconds before injecting into the bag. The reason is that priming with the BSS, it activates the inner layers of the cartridge. So this will help when you inject into the bag after waiting for 30 seconds, it will not get stuck. So sometimes we do unconventional. You know, these Bausch & Lomb people are very strict, stringent in terms of in their implying the technology or anything in terms of IOL or anything. So sometimes we go unconventional. Since they did not give me the toric one, so I used arcade here, and also priming I just put over the BSS. So in a couple of cases I got stuck with the lens. So this here I got away, but this is very important to be careful with this lens. Sorry. This is an interesting case I want to share with you guys. This patient, I implanted ICLs. And he's having -8 with 0.75 cylinder was his refractive error prior to the ICL. But unfortunately, in his right eye, he developed anti-subcapsular cataract. And left eye was quite normal. After 6 weeks, he came back to me saying, for first 10 days only, I was very good vision in my right eye, and then it started troubling. I couldn't see anything. Then it was so unfortunate. I didn't know what to do. I didn't want to put any multifocal because in the other eye, having good vision, and whatever little halo we see in ICL patients, they eventually they stop complaining. You know that aquaport that's hole in the ICL. But what lens I should give to this young man who did his pharmacy and is started working, and then I asked them, there's a lens available. It was 11.5, I think. So I immediately explanted and replaced with Lux Smart. And for the initial couple of weeks, because of the manipulation of explantation and then surgery, there was a little wound edema. He was having a little hazy vision, but then eventually he achieved 6/9 and N8. I was also, could sleep well after this good results. In the literature review, there were 2 studies with comparison with monofocal of this implant, and both showed good intermediate vision. And okay.
Because we have 2 more.
Yeah.
Combining 2 people.
Yeah. Yes.
To cover 2 people.
Sure. So all the studies were showing this good intermediate vision, but then pupil dependency was there in the recent study. They said there's a pupil dependency with this implant, and they targeted myopia of 0.25 and achieved 75% did not require glasses, but they did in inactive patients. But in my study, I implanted this lens in many active professionals, including few of my doctor friends as well, and with mini monovision strategy, this lens could provide all ranges of vision and make them, free from glasses.